So Preeti Desaigoudar is the newest addition to our child neurology group. Preeti is a genetic counselor and completed her training at the Children's Hospital of Colorado in genetic counseling and has already provided a great service to many of our patients on genetic counseling. So I appreciate you speaking to us this morning, Preeti. Thank you.
Yeah, of course. Thank you for that introduction. I'm really happy to do this. So yeah, I guess I'll get started. Hopefully you guys can all see that.
Yes.
So I really wanted to start by saying that this talk is really mostly focused on logistics. So in the last 6 to 7 months that I've been here, there are some, various issues and, situations that have come up. And I wanted to focus on addressing those. Some of it may feel like obvious or you've heard it before, but I'm trying to speak to everyone in neurology. And so I wanted to give sort of a baseline information to everyone about genetics. So I'm going to start with talking about genetic testing, and then I'll talk about referrals and the referral process to genetics. So I have nothing to disclose. These are my learning objectives. First, to talk about genetic testing, how to better use it, and then how to refer to genetics, specifically myself versus Dr. Brock, who is our neurogeneticist, versus pediatric genetics, or like more of the general genetics. So first we'll talk about genetic testing. I think the biggest issue that I come across is insurance and genetic testing. And I wanted to give you guys just sort of a broad overview of which labs work best with which insurance. So with Kentucky straight Medicaid, so this includes things like Passport and WellCare, there's no restrictions. And so from a perspective of genetic testing, it's really the best insurance to have. With managed Medicaid or Indiana Medicaid, it's a little bit trickier. You can't, so Invitae is obviously one that we use a lot and they'll work with it, but for other sort of larger testing, and I'm thinking especially like Exome, GeneDx is really great for that because they automatically take managed Medicaid, like Indiana Medicaid, and so you don't have to worry about out-of-pocket costs there. With private or commercial insurance, this is the trickiest. It really does depend on the individual policy and the deductibles for the specific family. I will say for GeneDx, they have an instant benefits investigation. Anytime you order a test, you can run that. And it's really helpful to give you an estimate. It's not an exact answer, but to give you an estimate of what the patient might owe. PerkinElmer, in my experience, is really the best lab, especially for like Anthem, I want to say. They're really the best lab with working with with that insurance. I also wanted to mention that when a patient has secondary insurance with, so often they'll have Anthem and then they'll have something like Medicaid or WellCare, I recommend GeneDx because whatever Anthem doesn't pick up or whatever the private insurance doesn't pick up, the Medicaid will pick up the rest. For inpatient testing, insurance doesn't matter because we automatically go through institutional billing. And then I know I'm bringing up one lab, M&G Labs. I know a few of our providers really like to use that. Unfortunately, they don't work with insurance right now. I hope that changes in the future. I know that providers like to use their repeat expansion panels and such, and unfortunately in those cases you're going to have to go through institutional billing and there's just no way to know what the patient may owe. So as far as common panels that we use on a regular basis in neurology, I think probably the number one is Invitae's epilepsy panel, as well as their other panels. I wanted to remind everyone, in case you guys are not aware, there is a sponsored free test called the Behind the Seizure panel for anyone under the age of 8. And I would say that for any panel, it's really important to provide clinical notes for insurance purposes. So this is especially the case for commercial insurance, I would say. Often even if you don't put it on the front end, they will reach out to you and ask you for them. So just like your office note is really going to be helpful there. And then for Invitae, I want to point out that, and I'm going to talk more about this as we go on, but not all genes are necessarily equally relevant. So with Invitae, you can add on a lot of these like preliminary genes, and sort of I want you guys to be aware of the fact that anytime a VUS comes back in those, there's really not much we can do. So, it's sort of good to keep that in mind that, with Invitae, it's just, there's not all genes matter in the same way. For a chromosomal microarray, I wanted to point out that most of the time we are doing using blood, and I would say for that, there is an EPIC order, as you guys know, that you just put a CGH in, and the lab knows to draw blood. However, there have been a couple of times where you have guys wanted to order microarray with saliva, and this is for maybe patients that don't live nearby and they live far away, or it's like a virtual visit. There you have to put in a miscellaneous genetic test in EPIC and actually specify the microarray, and then you have to put the order in yourself on Invitae. So that's something to keep in mind. With the microarray, I think we obviously talk about copy number variants and deletions and duplications. I wanted to bring up that there are a couple of things that can come back with the microarray that not everyone is always aware of. One is areas of homozygosity. So that's, and that can happen. And I honestly have had it several times now, which can indicate things like uniparental disomy. It can indicate consanguinity. And so that's something to keep in mind, that it's not one of the more obvious results. And then sometimes you'll get findings that are completely unrelated to the phenotype. So you might get a CNV that maybe has like a risk for, let's say, cardiovascular disease. And so again, with microarray, it's a broad test. And so really you can pick up a lot of things. And this has come up a few times. I've been asked, by multiple providers about a hypotonia panel. And so I wanted to make sure we were all aware of this. There is a newborn hypotonia panel through St. Francis, and the actual code that you put in for EPIC is the hypotonia panel, and that's the thing that comes up. What is important to know is they test for three things. So myotonic dystrophy type 1, and they do repeat expansion on that. Prader-Willi, but not Angelman of note. So it's only testing for the area that's associated with Prader-Willi. So you cannot make a diagnosis of Angelman with this. And then also SMN 1 and 2, and that's they detect the exon 7 carrier status. Of course, with newborn screening, the SMN is probably slightly less important, but still it's on there. So those are the three things that they test for. For ataxia and repeat disorders, I want to point out that most panels do not include repeat expansion testing. Unfortunately, because the technology is just so expensive, most labs don't offer it. M&G is one of the few labs, and like I said, it is tricky getting, working to get it covered. So. The next part is talking about variants of uncertain significance. So this is really, I think, the number one referral reason that I get, if VUS is found on a panel, what do we do with it? I encourage you guys to always look at the inheritance pattern. So if it's recessive, a VUS almost never matters. So just keep that in mind. And then if it's dominant or X-linked, you want to know if there's free familial testing offered. So with Invitae, especially because we order so many of their panels, they'll say specifically that family testing is offered, and that's a good reason to pursue that. And then I encourage you guys, again, especially with Invitae's panels, don't always take results at face value, because a lot of genes that are on the panel are not necessarily related. Like with the epilepsy panel, there are a couple of genes that are included, but where the association with epilepsy or seizures really hasn't been proven yet. Things like SGCE, which is like a dystonia gene. And so when you get a VUS in there with a patient who has epilepsy, that's something to keep in mind. And then I wanted to let you guys know about my approach to how I approach VUSs. I'm not expecting you guys to do this, obviously, but this is just something to be aware of. This is what I do. Couple of questions that I look at is, does it fit the phenotype? What are the symptoms that the patient has? Has it been seen before in the general population in healthy people? That can kind of move you towards the benign or likely benign side. What kind of variant is it? So is it a missense? Is it a nonsense? Is it frame shift? Does it fit with the known mechanism for disease? Is it loss of function or gain of function? And does that variant kind of go along with that? And then is the gene well understood? And a lot of the times it's not. And there's really nothing you can do. And it just remains like a true VUS. Pathogenic variants, I would say, are very similar in terms of what you guys should be aware of. Again, always look at the inheritance. If it's recessive and the patient has only one variant, the patient is a carrier. They do not have a diagnosis. That's really important to note. And then if it's dominant and heterozygous, the patient has obviously the diagnosis. And then if it's X-linked, you always want to consider the patient's sex, so whether they're male or female, and the known mechanism, whether females or males are tend to be more affected or not. And so that's something to think about there. This is the other thing I think I get asked about a lot, family variant testing. So I'm going to focus on Invitae first because I think they're the most common lab that we do family testing for. So for their panels, their policy is if you get a pathogenic or likely pathogenic variant, the time limit is 150 days. So they will do free testing. And what's nice is there's no limitation on the number of people. So you can do as many people as you want, but it has to be within 150 days. With the VUSs, and this is where I've had some miscommunication with the lab, but I've confirmed this, that there is no time limit for VUSs, which is nice. Because a lot of the times I'm getting referrals where it's really been over 150 days. And so there is no time limit, but you can only test up to 2 people. With the chromosomal microarray, that policy does not apply. And this is where, it's a little bit of a downside with Invitae. So unfortunately, you'd have to order a whole entire microarray for the parent. And this is where I was bringing up there are really a lot of things you can find with the microarray. You can find out, consanguinity. You can find out other sort of unrelated findings. Really, the parent can come up with, a CNV that is just not in the proband. So there's a lot. There's potentially a lot of consequences from ordering a chromosomal microarray on a parent. And then there are specific areas, like the DeGeorge or 22q11, where you can do FISH for those specific regions in the parents. And right now it's a paper form with Invitae, which is very cumbersome, but is really the only way to do it. Variant testing at other labs. So with Perk and Elmer, and this is where I think Invitae has the advantage. They actually charge for testing for pathogenic or likely pathogenic. They don't give any covered testing. For VUS, it's similar to Invitae, so free for up to 2 VUSs for up to 2 family members, and there's no time limit. And GeneDx is similar. They have a very strict VUS program. In order to qualify for that, that's the covered testing option. And they'll specify on the report if it is covered. If not, then again, it's going to be at charge. So I'm going to spend some time talking about whole exome and genome testing. And I think the reason for this is, I want to emphasize the sort of intense involvement of this testing and the consent process, and why it can be better to consider the involvement of myself or Dr. Brock. So first off, both of these tests are very clinically driven. So the test is really only as good as the phenotype that's provided to the lab. So the more clinical information they get, the better chance of getting a diagnosis is really what it is. And often they don't get a lot of, when you're just kind of ordering just quick whole exome, it's much better if, one of us see them, because we provide sort of a broad scope of what the patient has going on. And then similar with the family history and the pedigree. So the labs really prefer to have that again, for the purpose of being able to analyze variants, whether it's de novo or inherited, if there's any other patterns going on. So that's one thing. And then the consent process is pretty involved. I'm going to talk about it on the next slide. And then the question of proband versus trio only, I would say the trio option is really preferred. The highest yield, diagnostic yield, so I'm talking like 45% around there, is only achieved with the involvement of both parents. It's much less when you have proband only, so that's something to keep in mind. The other thing is, I would say that oftentimes a lot of insurances require the involvement of a genetic counselor to get the test covered. So in that sense, there may not be much of a choice. For inpatient considerations, I think a few of you are already doing this, but now that I'm here, I'm happy to consult on these whole exomes and genomes on an inpatient basis if they're neurology related. For exome versus genome, so I think Dr. Rock and I are happy to order a genome, and we've done it several times now. But just sort of to keep in mind, I think we typically prefer exome just currently in 2022. And the reason for that is, genome has only recently become a clinical test. And so the robustness of the data we have for exome is just better than for genome. And I fully expect that to change in the next, 5 to 10 years. I'm pretty sure we're just going to move to genome, and I'm certain of that. But right now, I would say that exome, really in terms of the data that we have, is sort of better in that sense. And especially if you only have the proband, I would really just stick to the exome. If you don't have parents, I would stick to the exome. Now, there are a few cases where I would do genome, or I would consider a genome. So one is if the patient hasn't had a microarray, because a genome can pick up copy number variants. So that's one thing. If you're also suspicious of an ataxia presentation, I would also consider a genome, because the genome can potentially screen for repeat expansion. It's not diagnostic, but there is a lab that does a screening for 35 genes that include repeat expansion disorders. So the consent process, this is really where it's helpful to have me and or Dr. Brock involved. So aside from the obvious of like explaining genetics to families and making sure they understand the result types, there are a lot of consequences that can come out of this. So one is insurance, and I'm including here not just health insurance and employment, but like life insurance, long-term and disability, and there are very important limitations there. The military, so something you might not know is that a lot of the protections in place for genetic information do not apply to military. So TRICARE does not apply to in those situations. You can discover non-paternity. So if you haven't had that conversation, that can be a shock. And then presymptomatic conditions. So these are things like you can discover either adult onset or later onset type conditions where the patient is not necessarily symptomatic, but it can have some big impact. And then the second part of this is that there are the option of secondary findings. So these are optional things that the family can learn about. The main one is the ACMG 72 genes. So these are the 72 mostly adult onset conditions that are recommended by the ACMG as being appropriate to learn about. And this does include parents too. So not just for the patient, but parents can choose to learn about it. So there's a whole, potentially a can of worms there about what kind of information they want and what kind of information they don't want. So a lot of emotional and familial implications there about learning all of this info. And then the question comes of like, which lab do I choose, right? So I would say with, if you can, again, depending on the insurance, I would say GeneDx because of their exome expertise. So they're really the lab. They have sequenced, the numbers are over 300,000 exomes, which is far and above more than any other lab. And so from that standpoint, they have the best, they have the most curated data that is helpful for VUS and sort of variant analysis. The other thing about GeneDx that you should know, and this is why it's helpful to have us involved, is their secondary findings are opt out. As in, if you don't check the box, you will automatically get those ACMG secondary findings. And if families are not aware of that, then again, that can be a liability issue as well. With PerkinElmer, you can do both whole genome and whole exome, and I should note both of them include mitochondrial analysis, and GeneDx does include mitochondrial analysis for exome as well. You have to choose the plus option for GeneDx though. So if you just choose the regular whole exome, you won't get mitochondrial analysis. You have to specify that. PerkinElmer is really great for especially commercial insurance and TRICARE. They're really good. And I only recently learned this, they're really good at working with TRICARE. With PerkinElmer, their secondary findings are opt-in. So in that sense, if you don't talk about it, it's not going to, they're not going to report on it because it is an opt-in. And the other thing to note about PerkinElmer is they have a whole bunch of other secondary findings that are not recommended by the ACMG. And I've had a lot of discussion about this with Dr. Brock, and we feel that, the kind of information, so I'm talking like carrier status, like just any other sort of thing that they can report on, is just a lot of information to process and deal with on a regular basis. And so we just recommend sticking to the ACMG 72 genes if you're going to do it. I think that's what the practice we've instituted. I've already mentioned mitochondrial analysis, and then I also want you guys to consider reanalysis options. So sometimes there are labs that offer free reanalysis, and some don't. Sometimes it's a one-time, in your lifetime free analysis, and other times it's more often than that. And so that can kind of play into it as well. So now we're going to talk about a couple of interesting panels, I think, that I would, kind of encourage you guys to think about and be aware of. So GeneDx has this panel called the ASD Expanded Panel. It's also known as like the Neurodevelopmental Panel. It includes 2,500 genes. And it's ideal for patients with global delays, autism, ID, anything along those lines. And we often, Dr. Brock and myself, we often consider it for like an epilepsy plus neurodevelopmental phenotype. So where they have epilepsy plus delays or autism or ID or something like that. What's nice about this is it's on the exome backbone. So what that means is you can reflex to whole exome at a later date, without any of the extra process that we just talked about. So that can be really nice to have in your toolbox. With this panel, the trio option is preferred because, again, if you have parental samples, and variants come up, you can determine, for example, if it's de novo or inherited. So in that sense, the trio option is preferred, but the nice thing is you don't have to deal with any of the extra consent processes or secondary findings or any of that stuff that comes with the exome and genome. And if you do end up doing this, I encourage you guys to get parents' names and date of birth ahead of time. The reason for that is in order to put in their information, you will need that. And so it's just handy if you have that information. Similarly, there's this other panel. It's called the NICU Express panel, and Dr. Rock has now, I think, used this a couple of times now. And the reason we like this is, so this has 3,500 genes or thereabouts. It's ideal for critical illness in the neonatal or newborn period, so anywhere kind of under the age of 2. So these include neonatal seizures, it includes neuromuscular conditions, it includes other neurodevelopmental disorders. So anything that can present significantly in the newborn period, this panel is really great for. Similar to the ASD panel, this can also be reflexed to whole exome, and so that's another sort of advantage of doing it without having to resort to exome or genome on the front end. And with this one, the trio is required, so there's no choice here. You will have to involve parents. It's just the policy or the way that this panel works. And the the major advantage of this is you get a verbal report within 7 days. You get a call from the lab within 7 days, which can have a lot of implications if you need to make quick management or treatment decision making, like quickly. So that's sort of the quickness of this is really the advantage. So that's really what I wanted to address for the testing part. Now I'm going to talk more about the referral process. So I want to, again, I've had this question happen where providers want to know, how do we refer to me? How do we refer to Dr. Brock? How do we refer to the two of you? And so this is where I wanted to provide a little bit more clarity. So for myself only, there are some things that I think I can just manage on my own. And so that includes things like somebody who you want an exome or a genome for, where it's already a well-documented presentation and really only a pedigree, so a family history and consent process is needed. Family variant testing, number one kind of thing I do. So, where on one of the panels, there's family variant testing, and I'm happy to do that. Carrier status, so like a pathogenic variant, but only one in a recessive gene, and so that's a carrier status. And then this last option of like families interested in pursuing additional diagnostics. So what I mean by that is maybe these families are not yet, like maybe the provider and the family are just not sort of on the same page about whether or not they want to do additional evaluation. And maybe this is in combination with like a VUS discussion on a panel. That's where it might be helpful for me to just see them first off and kind of introduce the option of additional testing and gauge their interest to see, is this something they actually really want to pursue? And then we can schedule a follow-up with myself and Dr. Brock. The next part is myself sort of only seeing the patient, but with Dr. Brock available in the clinic if needed. And so these include things like a suspicious VUS in a dominant or X-linked gene, or a suspicious VUS on a microarray. So it's helpful to have Dr. Brock there because in case I need extra sort of interpretation input, I can get him if he's in clinic. So. And then these are all the indications for myself and Dylan together. So includes things like positive result or new diagnosis of a neurogenetic condition. And I say neurogenetic because any sort of other conditions that are more general genetic, I think might still be better referred to the general genetics team. So really neurogenetic, I think, is best for us. In the case of global delays or ID that have an unknown cause, especially with a negative microarray and a Fragile X. And this epilepsy plus, I've mentioned this before, so this includes patients that have epilepsy plus one of these things, so autism, delays, movement disorder, abnormal brain MRI, any sort of other thing, basically. There's also ataxia, so we're happy to see that. Suspected leukodystrophies, brain malformations, and then like a neurodegenerative process like Batten's disease. All of those are perfectly appropriate for myself and Dr. Brock. And then there's the Neurogenetics MDC clinic. And so this is really a monthly clinic that involves Dr. Farber, Dr. Asamoah, Dr. Brock, Kelly Jackson, who is a genetic counselor in general peds genetics, and then myself. And these are best for patients that have systemic involvement outside of the CNS. So either they have dysmorphic features and they, a full genetic or dysmorphology exam is beneficial, or maybe they have some skeletal abnormalities or cardiac issues, just something else outside of the brain and the nervous system. So how to make a referral? It's pretty simple. There's 3 options. 1, you can message me and I'm happy to let you know. 2, if you're pretty confident about, what you want to do with your patient, I would say message my scheduler, and her name is Kristen Hopkins. And then 3, you can place a referral to Peds Neurology and then specify myself and Dr. Brock, and that all of those will get to the right place. So I wanted to touch on this. So when you guys are making referrals, I wanted to encourage you to think about some things. So when I often meet patients for the first time that have been referred to me, the number one question I often get is, why am I here? Why am I meeting with genetics? So I just wanted to encourage you, the slide for the purpose of, a patient's initial reaction to a genetics referral may not be what you think it is. A lot of families' initial reaction is fear, worry, anxiety. Genetics is just, it may have a negative connotation for a lot of people. So I wouldn't, it's helpful, I think, to briefly explain to the patient why they're being referred to genetics. Even if it's just like a quick, like, we found this genetic change. We're not sure what it means, so we're going to refer you to someone, a genetic counselor who can speak about this. Like, just as simple as that. And any misconceptions you can address are really sort of ideal for me and for the patient, because a lot of the time patients come to me thinking that they have a diagnosis, and I've had to walk them back from that, and it's much harder to do on the back end than it is to address it on the front end. And then this other thing that I think Dr. Brock and I want to emphasize, it's really best for you guys to refer patients who want additional evaluation or who want additional testing. If families are not interested, it's just not helpful for you, for them to see us, because it's just, I think it's, it's just not, it's going to be a waste of time for everyone. So just make sure that they are actually interested in meeting with us before placing a referral. And then the last couple of slides I wanted to talk about are special situations. So these are things that have come up that don't really fall into any other part of my talk, but just wanted to address. Presymptomatic testing for family members. So I've had this happen now a few times where we've made a diagnosis in the proband, and now there are either siblings or other extended family members, and they want to get tested, but they're not symptomatic. So that's why we say presymptomatic. One of the things I want to emphasize is penetrance of the gene. And so things like, like DEPDC5 is one where there's incomplete penetrance, and there's well-documented reports of, families that have unaffected family members that are never going to be symptomatic. And so testing, young children is just, it's something to keep in mind, I think. So versus something that is more completely penetrant where, the chance of developing symptoms is almost 100%. So, that's kind of the difference there. And I have made a practice or a policy now. I am happy to test first degree relatives for either pathogenic or likely pathogenic variants. I'm happy to do immediate family members, but for extended relatives for whom I've never met them, I prefer either to meet them first before I actually think about doing testing, or I will refer them to the appropriate provider. So that's just something that I'm planning to do moving forward. And then the other thing I want you guys to think about is agency of children or adolescents. So, this is of course we, as providers, we obviously want to care for our patients, but one thing, we talk about in genetics is, choice. And so especially when it comes to presymptomatic testing, and if they're older, sort of over the age of like 10 or 11, these kids know what's going on. Like they have some idea of what may be happening. And so, making sure that, we're just sort of getting their assent, maybe not consent, but assent that, they are okay with doing this is really ideal if possible. The second situation that has come up for me is this is where, you guys maybe have ordered a panel. So the first picture on this slide, it refers a result from a panel, like a resopathy panel. And if you look at the underlined part, it tells you that there was a deletion of the entire coding sequence in NF1, but the part I underlined, which is the boundaries of this event are unknown as they extend beyond the assayed region. So this is really important because in this case, there may be a larger duplication, contiguous gene duplication or deletion in the patient. So it's really important for you guys to refer those cases to me to do a microarray. So in this case, I can tell you this patient was then tested and got a microarray, and she had a large pathogenic 17q11.2 deletion. So in addition to an NF1 diagnosis, she also had this deletion syndrome, and that definitely has implications for management and diagnosis. The last situation is sort of a tricky thing where and I've touched on this before, where we do a panel, and I'm referring specifically to panels here, especially because we order so much from Invitae, where we find a VUS or some sort of variant in a gene that may have an association with something that is not directly related to the patient phenotype. So I've underlined an example here. So, for example, the MDH2 gene has the preliminary evidence supporting a correlation with autosomal dominant pheochromocytoma. So a couple of things to think about here. What is the inheritance pattern that may have some implication? And I'm referring to like non-neurology things here. Is it even related to neurology? As you can see in this case, it may not be. And if it's a variant, I would encourage you guys to maybe use discretion with making referrals to other specialties based on VUSs. And the reason I say that is, again, families often come away with the implication that, and I've had this happen where they think, oh, my son is going to get a tumor, and which means cancer. And they come with this very anxious sort of situation, and to walk them back from that to say, actually, and in this case, as I've underlined, the association is there's very little. And in the case of MDH2, it was a single case report. So really, I would not say that that patient is at an increased risk for pheochromocytoma. So it's just something to keep in mind. Obviously, we want to make sure that we're not missing anything, and there's certainly cases where it would be appropriate to make referrals immediately, but just kind of keep it in mind that in terms of what the patient is taking away from the discussion. These are my references, and I'm happy to take any questions now, if anybody has any.
I wanted to thank you, Preeti, for this fabulous discussion. I think it's very important to kind of understand the role of a genetic counselor in these complicated conditions. I do have one question.
Sure.
And this is both for you and Dr. Brock. I think there may be members of the group that are practicing within the adult age range. And I wondered, in the multidisciplinary clinic, are you set up for seeing adults as well?
So I don't know if Dr. Brock wants to add to anything to this, but I think we seek like teenagers, so like up to the age of like I think 22 or something like that is what we see. But adults, I don't think are seen in this MDC clinic. Correct me if I'm wrong, though, Dr. Brock. Oh.
I think you're on mute, Dylan. You need to unmute. Yeah.
There we go. Sorry about that.
Okay.
I would actually be generally happy to see adults, assuming we haven't yet, for the most part, or at least we haven't seen adults that haven't already been associated with this clinic, right? But I think going forward, my hope would be that we would have the opportunity to see some adults, particularly those where it has been difficult, for example, to get maybe broad genetic testing approved, and there's a high suspicion for an underlying genetic condition, and they're motivated and all the rest. I think there absolutely could be some opportunities. I've had some discussions with Dr. Puri, from a logistical and I think institutional standpoint, it is option. We have yet to really see someone from, for example, referred from the university setting or from the adult Norton neurology program, but I think that is something that may change with some time. So,
that being said, there are a few indications where I would say there is a specific genetic counselor, Chris Siliberto, who actually works with adult, so like Huntington's disease, adult neurodegenerative conditions. That, at least, I don't know about Dr. Brock, but that should not be coming to me because there is a formal protocol in place for testing those adults. It's pretty rigid, and so Chris Siliberto is a genetic counselor at Norton and U of L, and he has a specific clinic for that. So I would refer those patients there. But otherwise, I would, yeah, stick to what Dr. Brock said.
For other questions, just please unmute.
Yeah, Preeti, I have a question. So
Yes.
I certainly underutilize the autism ID panel. Do you
Mm-hmm.
think there's a role of using this panel instead of microarray in some of our globally delayed, non-specific delay kids?
I would, and again, Dr. Brock can add on to this, but I would say that I still think microarray is a useful tool. Like, it's like a first line tool, and I think it's fine for doing a microarray first and kind of ruling that out, because the thing about the ASD ID panel is that it doesn't pick up large copy number differences, right? Because it's just on the exome, and so it's going to be limited to sort of smaller, like, deletion, indels and those kinds of changes, and so it's not going to pick up larger copy number variants. And so in that sense, I still think there is a use, I guess is how I would say it. There is a use for microarray, and if it's a negative, then I would say, certainly the ASD ID panel is a great next step for global delay. Yeah.
That's fair. Thank you.
I have a comment and a question.
Yes.
Thank you for your outstanding presentation. And
You're absolutely. My pleasure.
I'd like everyone to remember that 99% of the genes that we have are not human genes, they're bacterial genes. And there's increasing evidence that bacterial genes, which reflect the complex bacterial or microbial populations that we have, they're involved in learning and memory and lots of things interesting in children, autism and other things. And my question comes from ignorance, but my favorite example of the interdependence of genes and environment is PKU.
Mm.
So it's important that people know that the genes are not, they don't work by themselves, so that it's possible. It's not just a theory that if you know how a gene works, you could fix it very easily.
Yeah.
But am I correct that a diet resolves PKU completely, and that these people live a normal life?
I think there are some, I think there's a little, it's not, I guess, a black and white answers, I guess how I would say it. But yes, I mean, PKU is one of these few conditions where diet does have a huge impact on outcome, but it really does. I wouldn't say it resolves it entirely. It brings down the phenylalanine levels down to within sort of a range that is appropriate or good for long-term outcomes. But aside from diet, there's a lot of other things that actually play into better outcomes for a patient. So things like therapies, things like resources, the kind of and treating any other sort of part of it, I think is just as important as diet. But I don't know if anyone else has anything to add there. So those would be my thoughts. But yeah, absolutely agree. It's definitely, there's a lot of interconnectedness and interrelationships for sure.
Thank you. Thank you.
All right. Well, thank you very much again, Preeti. We really appreciate it.
Of course. It's my pleasure.
All right. Everybody have a great day.
Thank you, Preeti.
Yep.